U of I when they started this.
Welcome back to Time TV's On the Edge. I'm Dr. Jonas Moses. With me this hour, Dr. Janet Hayes, Dr. Joan Flanders. We are talking about cardiology this hour. We're talking about some special procedures, imaging techniques, and hopefully we're going to get into some interesting cases as well, maybe talk a little bit about some of the clinical findings. We were, just prior to leaving for a commercial break, talking about the echoes. And before we go back to the next slide, I wanted to ask you the difference between 2 and 3D echo.
Well, 3D is a higher level of 2D echo. Basically, the computer in the echo machine now processes, it's like an exponential amount more information, and then shows this. What you saw there was a 2D, but now it can flip the image around and show it in 3D. Almost looks like a three-dimensional CAT scan, or what you were looking at earlier in that volume rendered, and zoom inside the heart and look around. It's very useful for looking particularly at valvular lesions and seeing what the actual pathology, why that valve is leaking so badly, why it doesn't move, and that's very helpful, especially for surgeons, to say if I can repair that, or know that that looks too complicated, I'm probably going to have to replace that valve. And you know, many cardiologists get very experienced in their own mind. They can in their own mind create that 3D image, but this is very helpful for showing it up front. And it is just really in the last 5 years, I think, become well established technically, where the echo machines have it enough that you can actually use it on a day-to-day basis. Okay,
so if our question is, why wouldn't we use a 3D echo all the time?
It's a good question. It's mostly the cost.
Okay.
But on a physics level, basically, just like you can visualize a baby inside somebody, the sound waves are taken, passed through a computer filter, and then reconstructed. And computers can reconstruct an awful lot. We can actually take infrared image data and add to the amount of information to predict blood flow, and that's what's now being developed as another level of technology. The so-called 4D echocardiograms might actually also look at blood flow in addition to all the anatomy. So it's basically that our computers and our calculating capacity has gotten much better.
Okay. Well, let's take a look at the next slide. We are still looking at some echoes, I believe, here. So this is a stress echo?
Mm-hmm.
Yeah.
So since blood flow, you cannot see blood flow. What you see white against a black screen on traditional 2D echo is the tissue, and the blood becomes black. So to find out what your heart is doing at stress, you would like to see the blood, and you would like to define the walls of the heart better. So we actually colorize the blood flow with little teeny bubbles of air. There's a contrast agent that you inject in a patient. It intersperses within the blood pool, and it goes to the heart, because all blood eventually gets to the heart. And that'll show up white because, again, echo is all sound waves, and how sound waves bounce off different tissues. So the black here now is the walls of the heart, and it's a prettier picture if it's a moving image, because you actually, stress echo is, you visualize the walls of the heart, and as they move, and you can infer blockages because of the way they move during stress.
Let's next slide, please. So this is an MRI through the chest, sagittal view, is that what you would call it?
Sagittal, yes.
All right.
Mm-hmm. And MRI, once again, MRI is a pretty sophisticated technique, and you can either use it to have the blood inside the heart to be black blood or white blood, depending on how you set the spin of the machine. And it is very useful, once again, for anatomy of the heart, and because you can see the blood moving through for the function of the valves in particular. And this, once again, almost like CAT scan, you can focus just down on the heart level, or you can see the entire chest. So that and CAT scan are sometimes useful for seeing other causes for chest pain, for example, than just the heart. For example, you may see a aortic aneurysm that's dissecting, or a hiatal hernia, or pulmonary embolism, something like that. And as I said, this is one particular view, but then you can slice it in many different views depending on what you want to look at.
And you were, Joan, you were talking earlier about the esophagus, the fact that you could. Can we have that slide back up for just a second, please? There you go.
Actually,
so there, the esophagus is somewhat flattened. You were talking
exactly.
about the difference between a flattened esophagus, which would be a normal view, and one that is has been dilated.
Exactly, and you can imply a lot from that. To orient the viewers, so at the very top is the sternum or the breastbone, and then the heart is right under that. And then the small little oval kind of grayish area in the white area right behind the heart is the esophagus. And if you think about it, the patient is laying flat, and when you're laying flat, nothing from the stomach comes up into your mouth, so the esophagus should be flat and free of liquid or air. So if you do see that it's open or full of liquid or air, you can infer that the valve, the esophageal sphincter, is incompetent, and that's very, very highly related with gastroesophageal reflux disease, which can cause chest pain that even mimics heart pain. So it's very nice because if you have something pushing on that area, you can diagnose the cause of chest pain that doesn't have anything to do with the heart, and obviously you wouldn't want to have to go to a cardiac catheterization if you just had an ulcer.
Indeed. Next slide, please.
This is MRI that is looking specifically at the coronary arteries, and I believe that this...
It actually looks like an aneurysm, pseudoaneurysm of the left ventricle.
Wall. Yeah.
In this case, the blood is white, and this is cutting through, on the left-hand side, the two ventricles side by side. The brighter white is the right ventricle, and then the smaller concentric circle, that's the left ventricle. And if you look at the smaller arrows on the bottom, is pointing to an outpouching of some of that white blood. And this is actually showing an actual pseudoaneurysm, another cause for chest pain, in that particular dimension. And then the B slide shows it from a different cut, a coronal cut. But as I said, MRI is particularly useful for spinning things around and showing things in different ways. And it's also very, very good for showing infiltration of the muscle wall itself and showing if it's not muscle, if it's been infiltrated by scar or fat. MRI is one of the best techniques for actually distinguishing different tissue densities like that.
Okay, and our last slide, please. So this is a CT of the pulmonary artery in the left atrium. Mm-hmm. And what can you tell us about the landmarks there? Why is this useful?
Well, just as Janet said, sometimes you see pulmonary emboli as a cause of chest pain. I believe that that's what this study is trying to demonstrate, dilations of the pulmonary arteries and then the anatomy of the pulmonary arteries.
It looks like it's actually showing pulmonary veins as well, which once again turns out to be pretty important for the electrophysiologist, because when he needs to ablate certain things, he needs to find them.
Good. We're going to a commercial break. We'll be right back. Stay with us. You're watching In Time TV's On the Edge.